So good morning, and thank you to the organizing committee for inviting me to speak today. I will try in my own inadequate fashion to provide a sense of the HIV/AIDS epidemic over the past 30 years, actually a little bit more. I do so from the somewhat narrow perspective of having been a Toronto physician who first encountered the AIDS epidemic through the large numbers of gay men and injection drug use in my medical practice in the late 1970s. And later having worked in a small sub-Saharan African country called Lesotho, which is a landlocked country surrounded entirely by South Africa. I just say this because when I tell you my own experience, I can only do so without reference to HIV-infected transfusion recipients, another group disproportionately affected by HIV, but I mean no disrespect to transfusion recipients by failing to describe some of their stories. Let me begin with a true story, and it has to do with the AIDS epidemic in the late 1970s and early 1980s in Toronto. At that time, a group of about a dozen downtown Toronto general practitioners or primary care physicians had large numbers of gay men, and some of us had injection drug users in their medical practices. I was one of those downtown doctors at Parliament in Wellesley. Each of us had patients at the time who experienced a fair number of sexually transmitted diseases: gonorrhea, acute hepatitis A and B, lymphogranuloma venereum. But we also had patients at the time who presented to us with very weird types of infections similar to mononucleosis. People who come with fever, rash, swollen lymph nodes, sore throat, and minor laboratory abnormalities. And we went through the usual investigations doctors do, never having come up with a diagnosis for these infections. And they actually resolved within several weeks and went away. And we just kind of attributed this weird mono-like illness to just another maybe weird viral STD that these mostly men picked up. But none of us were able to put these individual stories together and never queried or wondered whether some common or new biological condition could be explaining these occasional weird infections that we saw in our medical practices. Yet an epidemic, of course, the AIDS epidemic, was exploding before our very eyes at the time. We were never trained to gaze beyond the individual patient in our office, look beyond the patient and wonder, could there be some common phenomena? We were actually stuck in treating the individual in our office without looking at the community the person came from. And it was really a failure, I think, of our medical education. It's still a weakness in medical education, in that students are really not trained to gaze beyond the individual patient and try to identify the external conditions or circumstances that could be making their patients sick. Sometimes towards the end of 1980 and early 1981, those same downtown doctors began to hear rumors of a strange disease that was affecting gay men. These stories and rumors and tales mostly came from our patients who were visiting friends, lovers, and partners in the United States. And rumors were being spread of a life-threatening pneumonia, a weird, very uncommon skin cancer called Kaposi Sarcoma that was afflicting gay men in large urban centers in the United States, particularly in Miami, New York City, and San Francisco. And finally, on June 5th, 1981, the Atlanta, Georgia Center for Disease Control in the United States published the first report of 5 gay men who'd been struck with a life-threatening pneumonia called pneumocystis carinii pneumonia. Now it's called pneumocystis jirovecii pneumonia, but then it was called PCP. This was the first official medical publication of this new disease called AIDS. I could never normally claim that I subscribed to that publication, because I didn't, but my partner in medical practice at the time, Dr. Michael Rackless at the South Riverdale Community Health Center, did subscribe to the CDC report. So fortuitously, I was able to read the first report describing PCP soon after it was published. And mystique quickly arose about the new illness. Most physicians had never seen and perhaps never heard of PCP pneumonia or Kaposi sarcoma. I remember in 1981 or 82, after first reading the reports of KS, which came out in about August or September 1981, I had a gay male patient who I referred to a dermatologist because he had a strange-looking skin lesion on one of his arms. I had no idea what KS looked like at the time, so that was the reason I referred him to a dermatologist. And the dermatologist, his name was Colin Ramsey, he's actually since died a number of years ago, was a very kind, humble, self-effacing man. And he phoned me up and he said, look, I have no idea what Kaposi sarcoma looks like in a gay man. And he further stated that he knows no more about it than I would, and I knew nothing about it. The lesion was eventually diagnosed as benign, was called a fibroadenoma, but the patient was not as lucky because he eventually did test HIV positive and died of toxoplasmosis of the brain in 1994. The first few years of the early 1980s were very scary for the doctors. It quickly became apparent, in particular to the downtown primary care physicians, the 12 of us, that there were no experts in the field of HIV and AIDS. There were no consultants or specialists that we could phone or send our patients to, and there's very little or practically no medical literature published in the journals at the time. There were no alliances or collaborations because there's really no one to collaborate with in the very early 1980s. And just to give you an example of how little information was available, I actually used to clip by hand, like tear out articles from various medical journals as the few articles were published in HIV and AIDS and keep them in files, an unimaginable task today when there are tens of thousands of articles published on HIV and AIDS. The first alliance or collaboration for the downtown newly minted Toronto AIDS doctors was with an infectious disease specialist named Dr. Mary Fanny, who worked at the Toronto General Hospital. And Mary organized us. She organized the first meeting of these downtown doctors, and that led to the establishment of the Toronto HIV Primary Care Physicians Group in 1987, just in time for the major AIDS political battles of the day. The group undertook education activities with virtually no support. We did educate ourselves, and we occasionally had one of the very few experts in Toronto come speak to our group to try and educate us. You have to remember that the identity of the virus responsible for causing AIDS was not determined until the spring of 1984, and an Ontario routine HIV antibody testing did not become available until November 1st, 1985. Therefore, for the first 4.5 years of this exploding epidemic in Toronto, we had to rely entirely on our clinical assessment of the patients we saw to determine if someone may be infected with this strange virus that causes AIDS. I cannot exactly recollect when it became apparent that people at risk who were presented with enlarged lymph nodes or lymphadenopathy were likely to be HIV infected with the virus causing AIDS. But I do remember the kind of sinking, sick feeling we used to have, and I had in particular when detecting large lymph nodes, examining these men, because I knew that the discovery or palpating or feeling these lymph nodes meant the men I was examining were doomed men. Various acronyms were applied during those early years to describe men with the swollen lymph nodes, which meant they had signs of immunodeficiency. For example, there was persistent lymphadenopathy syndrome, or PLS. I still have it written in some of my charts. Gay lymphadenopathy syndrome, or gay-related immune deficiency. Now, one unique feature of the AIDS epidemic from the beginning was that politics, ethics, law, and in general how society reacted to the AIDS epidemic was inextricably bound up with the virus and the illness itself. And unlike other illnesses or infectious diseases, one of the groups, of course, struck disproportionately and in massive numbers in waves of dying friends, as one of the early AIDS activists put it, was the gay male community, a community with years of political experience, had an articulate leadership as they engaged in gay liberation struggles from really 1969 on in Toronto and the rest of North America. And those leaders transferred their skills and their expertise from the area of fighting for gay rights to the area of HIV and AIDS, to the train of medicine, science, and healthcare. And very quickly, those same leaders formed AIDS committees across North America. In Toronto was 1983, the AIDS Committee of Toronto was established. And the purpose was for prevention, for whatever they could do, education, demystifying the illness, and to provide service to the people who were beginning to die in droves. But that same leadership also challenged the very foundations of many institutions in society, including healthcare systems, the judiciary, the prisons, the education system in which kids who were HIV infected were being kicked out of school. At the Y in downtown Toronto, people were not allowed to swim in the pool who had HIV or were known to have HIV. The actual research enterprise in medicine was challenged. And the nature of the doctor-patient relationship, in which tradition held that the doctor was a dominant and powerful factor, was directly challenged. That relationship was directly challenged by these AIDS activists. In Toronto, really Canada, the preeminent AIDS activist group, and I'll go on to it now, was AIDS Action Now, which was founded in February 1988, shortly after the doctors group, the Toronto HIV Primary Care Physicians Group, was founded. They were founded at a public meeting in February, as I mentioned, in Jarvis Collegiate, and about 300 people attended the meeting. I happened to be there as well. And quickly after the formation, they organized a demonstration a month later in March 1988 at the Toronto General Hospital over the use of placebos in a trial testing aerosol pentamidine for the prevention of PCP pneumonia. And also protesting against the denial of requests for unapproved experimental AIDS therapies, which was just kind of coming down the line. The battle was won by AIDS Action Now in January 1989, when the then federal Minister of Health, Mr. Parambidi, relented and authorized the release of experimental drugs. The pentamidine trial was stopped. AIDS Action Now has organized dozens of actions and protests during those early years, including the burning in effigy of the then federal Minister of Health, Jake Epp. And believe me, that was a dramatic and historic event and immediately caught the nation's and the government's attention forever. The first major battle in Ontario arose after HIV antibody testing became available, as I mentioned, November 1st, 1985. HIV and AIDS were then reportable diseases, they actually still are, meaning that the physicians who tested people in their offices had a legal duty or onus to report the identity of people and all sorts of personally identifying information to local public health authorities. But the downtown doctors who were treating many gay men also knew that the people who were actually at highest risk for HIV would never come in for testing and counseling if they knew their identities would be reported to public health authorities. And gay men had good reason in those years to fear the state. They had for years been subject to persecution by police, particularly in Toronto. In 1981, as some of you may know, there were major raids occurred at 4 bathhouses in Toronto, which are traditionally a safe, secure, and peaceful place where gay men could have anonymous sex. There was no trust of anybody in government at the time. The gay community in 1985 was not exactly predisposed to trust public health authorities and the government with lists of men who tested HIV positive. They already had a list of men they busted in bathhouses. Therefore, as soon as the test became available, public debate ensued and a conflict arose between the leaders of the gay community, the newly formed AIDS activists, and public health officials. Those AIDS activists had the support of their doctors in a kind of an informal collaboration, informal alliance, and the doctors declared they would not be providing the identity of any of their patients to public health, any patients who tested HIV positive. Initially, public health authorities publicly in the media threatened to prosecute and take legal action against doctors who did not comply with the reporting requirements, but they actually never followed through. And one of our members, Dr. Don McCauley, who was a longtime HIV physician in downtown Toronto, refused to provide the name of a patient who tested HIV positive. It was in the newspapers. He was threatened with prosecution. It's kind of a daring and bold act for Dr. McCauley to do in those years. Part of the reason that public health eventually capitulated, not only to Dr. McCauley, but to Hasselfree Clinic, who were openly and illegally providing anonymous testing, totally against the law. Part of the reason they eventually caved was the public health authorities could actually never tell us what they're going to do with these names, how it would benefit the community to have lists of people. It served actually no useful public health purpose. They understood they could do no contact tracing, which was the traditional reason they wanted names. And further, by the late 1980s, there were reports published in the medical literature and at peer-reviewed conferences that, as I mentioned earlier, the very people who you want to invite in for counseling and testing, the highest risk people were the ones who stayed away if they knew their identities would be reported. And therefore, we were able to actually not only rely on our political instincts and our knowledge of the community, but on the medical literature at the time to back up our belief that people at risk would not come in if they knew they were going to be reported. These battles actually with public health took place on radio and on television and newspapers. There were debates in CBC morning shows. I remember I actually had a debate with Dr. Jay Brown I'm going to talk about in a few minutes. They also took place in deputations of committees of the City of Toronto, municipal government. I recall in 1988, the then Chief Medical Officer of Health for Ontario, Dr. Richard Shabas, said, "There will never be anonymous testing in Ontario as long as I'm the Chief Medical Officer of Health." Well, in September 1988, AIDS Action Now began its campaign in support of anonymous testing. And Dr. Shabas eventually went, after being confronted by nearly every AIDS organization in Ontario, over his call for quarantine in some circumstances of HIV-infected people. And in October 1990, the Ontario government, Ministry of Health, actually agreed to provide anonymous testing, so we've now had them for 24 years, largely because of the pressure of AIDS Action Now and the HIV Primary Care Physicians Group. The alliance between AIDS doctors and AIDS Action Now over access to experimental medication and over the anonymous testing fight was spontaneous and crystallized in a more official, formal way in December 1990, when both groups held a widely publicized joint press conference demanding that incentives be put in place to induce and encourage doctors to treat people with HIV. This was, after all, a time when many HIV-positive patients were being kicked out, dumped from their regular GP's offices only because they had HIV, and all of us, including myself, saw patients experience that. We knew it firsthand. We actually used to track doctors and dentists who were dumping patients to see if they could be held accountable by the regulatory authority, the College of Physicians and Surgeons, but nothing actually ever happened. There's an iconic editorial in the Journal of the American Medical Association in 1987 by a leading Catholic bioethicist named Edmund Pellegrino, where he was discussing the phenomenon of doctors kicking HIV-infected patients out of their regular practices. And the title of the commentary was Patients Without Physicians, the Newest Epidemic. You can probably still Google it and find it, but it was a real phenomenon, hard to believe, but it did happen. From the beginning, as I've told you, leaders of the gay community became leaders in the struggle against AIDS. They did challenge the medical establishment and the research establishment in medicine from the early 1980s on. There were no remedies or therapies available at the horizon. There was a lot of flashes and explosions of anger by the AIDS activists. Even at international AIDS conferences, some of the leading researchers had fake blood thrown on them, I remember. But a constructive consequence of the rage towards doctors and scientists who had failed to provide any useful therapies in those first numbers of years, and towards governments who were completely neglecting the AIDS epidemic and not providing really any decent funding for research or treatment. One of the constructive consequences was the demand by AIDS activists that people with HIV or AIDS be represented or appointed in any type of committee or government process or hospital advisory committee or university ethics committee that was making decisions about them. They did not want the institutions to be making decisions on their behalf. They wanted to be there making decisions on their own behalf. I was lucky enough to be invited to the first national meeting of AIDS researchers in Canada, which was held in London, Ontario in November 1988. Even though I can't pretend to be a researcher, I'm not. But there were no AIDS activists and no leaders of AIDS service organizations were invited to this first national conference of about 200 clinicians and researchers and scientists. But of course, the AIDS activists rented rooms in the hotel. They organized a press conference announcing their exclusion. They held protests outside the conference room where the meeting was being held. The conference organizer was Dr. John Roydy, who was a dean of the Faculty of Medicine at the University of British Columbia in the late 1980s. And the situation struck him and others as kind of strange, odd, didn't have to happen. He was a smart guy and decided he was going to go out of the conference room and directly meet the AIDS activists, which he did. And one of the results was he invited them to join the rest of the meeting. So about half a dozen of the protesters actually joined the rest of this 2 or 3 day conference. And one of those activists was a man named Chuck Grochmill, who actually died in Casey House in 1990, about 24 years ago. He was a regular columnist for Extra Magazine, the Toronto Gay Community Magazine, and he did not mince words. His writing was the way he talked. He just got right to the point. He was quite direct. And at a key moment in this conference of 200 people, 10 people at 20 round tables, he just stood up and he gently pounded his fist on the table just like this. And he declared to AIDS researchers that, and I quote him, "We, meaning the patients, can stop any clinical trial we want to at any time," meaning that if they were not going to be included in every scientific committee, ethics committee, etc., advisory committee of governments, then the patients would paralyze and freeze their research. And Chuck made it very clear that their research, their academic careers, their professional aspirations would go absolutely nowhere. And the room felt completely silent, like absolutely one of those, you could hear a pin drop moments, forgive the platitude. But the AIDS researchers at the time, many of them were very good people and are still in the field a quarter of a century later, realized that the relationship between patients or research subjects and the research and medical establishment had forever changed. And today, of course, people with HIV and AIDS are represented on every type of committee conceivable at which decisions are made about their lives. They include provincial and national AIDS advisory committees, scientific and ethics review committees of the Canadian HIV Clinical Trials Network, government working groups, hospital community advisory panels, international AIDS conference organizing committees. They're really everywhere. And in fact, the inclusion of HIV, this was not anticipated by the researchers and doctors, actually benefited the researchers and enhanced the research because its proposals for research were vetted and approved and reviewed by the very representatives of the community who were going to be the research subject. The research had a lot more credibility with potential research subjects, knowing that their own community was involved in improving the protocols. So I think today it's fair to say that people with HIV and AIDS have joined in an equal partnership with AIDS researchers to not only promote research, but to effectively lobby government for funding research, for example, or for increased clinical services. It was actually symbolized, this partnership, at the San Francisco International AIDS Conference, which I think was held in 1991, when there were two separate demonstrations. There was one demonstration in downtown San Francisco with the community groups and people with HIV/AIDS and the AIDS activist organizations. There was a separate demonstration of white-coated researchers and clinicians in a different street in San Francisco, and they met at a common intersection and joined together to symbolize the fact they were coming together to fight what was really the common enemy, which is the virus itself. So for the first 14 or 15 years after AIDS was first reported, serious illness, deaths, and very little hope, to be quite frank, characterized the epidemic. And although small strides were made here and there in the late 1980s and early 1990s, illness and death rates were not substantially reduced until 1996, of course, especially after the International AIDS Conference in Vancouver, with the advent of combination therapy or HAART, highly active antiretroviral therapy. In the 1980s and early 1990s, many doctors, I can tell you, felt totally shell-shocked as they watched their patients wither away and die after a ferocious onslaught of many, in one body, many life-threatening tumors and infections. And doctors could do very little except rely on the most noble traditions of medical practice, which are to be kind and unconditionally available. In many of our medical practices, 4 to 6 patients a month were dying. A number of us regularly kept death certificates in our homes, in case we were called at nights and weekends to declare people dead. We bore witness to entire social groups that were wiped out by AIDS. No reminiscing, no remembering significant events, no collective memory for these groups of men, and no evolution of group relationships over a normal lifespan. They were decimated. I and other doctors learned a lot during those years about human dignity and courage. And one of the most dreaded conditions I referred to earlier was Kaposi sarcoma. Men with Kaposi sarcoma were marked men. The hideous lesions of KS would erupt on skin, in people's mouths, noses, lungs. Also would penetrate internal organs like the lung and gastrointestinal tract. They're often widespread, these lesions, and would sometimes obstruct the normal lymphatic drainage in people's bodies, which led to severe swelling of their arms, legs, neck, and the face of those struck with Kaposi sarcoma. I remember one man who was actually a poster boy for a gay community activity and event annually. He was a pretty and handsome blonde-haired guy in his late 20s, but he was struck with a very aggressive and rapidly spreading Kaposi sarcoma. And within months, he barely had any skin area, which is actually free of these purple, nodular, grape-like lesions which covered his skin, which are typical of KS. His face and chest were literally covered with these lesions, and of course, his face became swollen and distorted, and he lost all his elegance and pretty features. But he would come to my office with the top 2 buttons of his shirt, top 3 buttons undone, showing half his chest, and sit kind of proud and erect in a packed waiting room of patients. And I once sort of commented, I said, geez, you know, I really respect you for the way you come in here in public, for your persistent effort to kind of lead a normal life and not try to be somebody else. He responded by saying that he had considered his condition, he knew what he looked like, couldn't deny it, and decided that he had 2 choices. One was to live hidden and closeted in his apartment, and the other was to live openly and freely despite his horrific appearance. I learned another lesson from this man. He would, as I mentioned, he would visit me approximately every 2 weeks as he became sicker, and I would routinely listen to his chest with my stethoscope. As I observed his quick decline, I began to wonder why I was going through this ritual of listening to his lungs, because it was a practice that had absolutely no benefit, no clinical benefit or use at all. I'd hear abnormal sounds, I could do nothing about them, completely medically useless. But I realized, on considering that in the process of listening to his chest with my stethoscope, I would place my stethoscope on his back, ask him to breathe in and out. I couldn't help my fingers, which were over my stethoscope, actually touching his Kaposi Sarcoma-ridden body, including the lesions themselves. And if I'd actually stopped listening to his lungs, I would have stopped touching him and de facto rejected him, a reaction that was common towards people with HIV/AIDS at the time, especially in doctors' offices. So I just kept on the ritual of examining the patient only in order to lay my hands on his Kaposi sarcoma, not because it benefited him all medically. You know, the fear that was constant, and there was terror among people with HIV and AIDS during those early years, led to a variety of reactions. One was the patient I just described. Another reaction, which in my mind was not actually unreasonable, was a kind of personal denial of the symptoms which were afflicting men at the time, even symptoms which could indicate a life-threatening infection. I had a cousin of mine who died of AIDS, and he just pretended until his last days that he never had it. I remember that 3 months before he died, our family tried to convince him to go to Casey House, and his answer was, he was covered with Kaposi's also, his answer was, Casey House, only people who are dying go to Casey House. And he did die at the Wellesley Hospital eventually. But I'm going to tell you another story about denial and strange alliances. It's about a woman I'll call Sharon. She came to Toronto from the Maritimes in the early 1980s and became addicted to heroin shortly after her arrival in Toronto. She also became infected with HIV. She was extremely reluctant to take any medications for any condition or to have any tests or investigations. And one day she came to my office quite short of breath and with a severe bloody cough. I had a medical student with me at the time, actually, and I tried to persuade her to have a chest x-ray, but she absolutely refused and was adamant there was no way she would get the chest x-ray. I asked her if there's anything I could do, this is 10 minutes later, to convince her to get a chest x-ray in order to determine the possible treatment or diagnosis. She said, absolutely nothing you can do. Now, she had a good sense of humor, and she was the type of person who you could just kind of grab your heart. She was sort of sweet-looking, there was nothing but sort of goodness about her. No bitterness, no anger, no resentment. I don't know where I got the idea from, but I finally blurted out, well, if I sing you a song, would you get a chest x-ray? So she broke out laughing and said, okay. As it happened, I had young kids at the time, this was many years ago, and I was singing the Elvis Presley song, Heartbreak Hotel, in my car when I dropped them off at the daycare. So I kind of knew the first two verses, which I normally didn't know, and I sung them to Sharon. The medical student, of course, his jaw was dropping, his eyes were open wide, like, what is this guy doing? But she actually did get the chest x-ray, and she was successfully treated for pneumonia. And the incident was an illustration of the flexibility, I think, required by many doctors at the time in contending with a disease for which little treatment was available. And it also shows you the connection or collaboration between song and AIDS, so I'm telling you the story. But Sharon and her husband, who was also a heroin addict and HIV infected, did more than teach me about flexibility. Sharon was the second patient for whom I prescribed methadone. That was in late 1991. Now, methadone, it's going to be a quick academic primer on it. Methadone is a highly addictive substitute for heroin, but it is legal. You don't need to know the details other than to know it is like codeine or OxyContin or morphine. It has all the same characteristics. It has all these same effects of any other narcotic. It produces maybe a mild euphoria, but not very much. What it does do is it prevents cravings for people who are on it and withdrawal symptoms for people who are initiated on it. It is legal and approved, whereas no other narcotic is. So if I have someone addicted to heroin, I cannot give them morphine legally. Morphine is only allowed for pain, not for addiction treatment. It's considered the gold standard in treating opioid dependency. For those who are actually on it, if they do use heroin, it blocks the effect of the heroin. And more importantly, it welcomes addicts into the healthcare system more than for addiction, so they can get other types of care, especially for HIV, which many had at the time, but also for hepatitis B, hepatitis C, any medical condition. The mortality rates and HIV and hep B, C transmission rates and crime rates in communities where methadone is widely available. It's much, much lower than in communities where it's not available. This has been in the medical literature since the mid-1960s, actually, and it does give people a chance for some type of stability in their life. It's an example, which I'm sure you all know, of harm reduction. I'm not going to give you a lecture on it, but the idea of methadone was not to necessarily abandon the opioid addiction. It's to reduce the harm and injury, sickness and death associated with its use, and it does not require abstinence. So people on methadone are not abstinent. They're using a narcotic, which is why governments had great objection to its widespread use. They couldn't get their head around the fact of why would you treat an addict to opioids with another addictive substance. And it's measured, and this is quite important, the benefit is not measured in the change in rates of drug use or behavior, it's measured in the change of things like death, disease, and suffering, as written here on the slide. So that's a brief primer on methadone. So, as I mentioned, Sharon came to Toronto, and she actually was put on methadone, and she was totally off heroin, abstinent for 2.5 years until her pain from AIDS required a switch to a continuous subcutaneous infusion of morphine, which she did take until her death. So she was off methadone because she needed pain control. She'd been struck with a debilitating peripheral neuropathy, which literally means a condition which produced a fiery electric-like pain down both her legs, and in fact eventually paralyzed her. She died from a rare AIDS complication that I've not seen for years, but I saw about 6 people who had it, called progressive multifocal leukoencephalopathy. I can hardly pronounce it myself. Or PML, which is an unusual AIDS condition which punches holes at random in people's brains. Sharon died completely hallucinating, psychotic. She was unrecognizable. Her sort of soul kind of departed because of this condition. But she did die at home in my own neighborhood, 6 blocks from where I live, and I always sort of mused in a way that she died, as it said, in my own backyard. As I mentioned, she stayed on methadone for the last 2.5 years of her life, and once she was off heroin, she became, as the preachers might say, kind of repentant. She sought the solace of religion and God. She'd been raised in a religious family and in a devout and loving religious Catholic family. And she actually reunited with her family, who I met a few months before she died. They flew in from the Maritimes. Her brother was a cop, actually. She really could have been a member of your family or mine who's gone astray, but it really was the availability of methadone in the context of receiving comprehensive primary HIV care at the time that permitted a somewhat normal life and reconciliation with her family. Now, addicts are unlike any other patient group. Yes, there are some addict lobby groups in Vancouver. There's an intermittently active one in Toronto, but they're mostly an atomized community without leadership and organization equivalent to that of other patient groups, especially gay liberation AIDS activist groups. And the absence of an effective addict lobby group means, and it's meant, that governments, institutions such as the judiciary or the healthcare system or jails have never been really held accountable for the manner in which they treat or confront addicts. Within a few months after I began to prescribe methadone in 1991, our little medical office of Parliament in Wellesley was flooded with phone calls from heroin addicts desperate for methadone treatment. The word gets out very quickly. I was in a 4-doctor office. One of my colleagues, Dr. Abe Hirsch, joined me and started prescribing methadone at the time. So at that time, there was a public health nurse named Mary Grondin, who eventually ended up at the Sherburne Health Center. She was seconded to my office. We decided we got to do something. So we organized a widely covered press conference early 1992, at which 3 addicts and I spoke publicly about their addiction and the unavailability of methadone treatment. I remember the press conference pretty well, actually. My hair was a little bit longer, probably as long as Ann Stewart's is now, and the media had trouble figuring out who the doctor was and who the addicts were. I just raised that to show you that stereotypes don't hold for anybody, whether it's addicts or doctors. But the press conference was actually quite successful. This is the Globe and Mail, and this is really the first time that I was aware that any addict, heroin addict, active heroin addict, was publicly identifying themselves. Of the 3 addicts, one's alive now, the other 2 have died. It hit the quote of the day in the Globe and Mail. It's pretty good. Couldn't do much better than that. Toronto Star, Kelly Toyle was a prominent health reporter at the time. That was February 7th, 1992. I like the title from the Ottawa Citizen, methadone program in dire need of a fix. and really what we could not have dreamed of, an editorial in the Globe and Mail from the Globe Mail on the editorial page. You just could not do better than having the editorial supporting a political position. So it's quite a dramatic and fantastic response, and we felt a successful press conference. The only problem was the provincial government of the day, an allegedly social democratic government, the NDP, took a completely reactionary position and would not budge on the issue of methadone. They described the methadone treatment as controversial. I remember Francis Lankin on TV saying Dr. Berger has a controversial view and others don't agree with him. It got kind of personal. They just wouldn't move. One of the unpleasant results was that the number of calls to our office just escalated after that because the word really got out that we were giving out methadone. Don't forget, at that time, there was about 150 people in Ontario. That was it on methadone. Most of it out of the Centre for Addiction and Mental Health. Our office was one of 2 offices in Toronto giving methadone in the community. And as well as phone calls coming in, there were actually people dropping into our medical office without people we didn't know, who weren't our patients, demanding to see myself or Dr. Hirsch for methadone. It was completely unmanageable. And it occurred to us, well, you know, our secretaries manning the front desk had to hear these cries for help. Why do they have to hear? Let the Ministry of Health hear the cries for help. And after all, it's the Ministry of Health's responsibility. It's the state's responsibility for administering health care, not ours. Let the ministry representatives hear what our secretaries and we were hearing from these desperate patients. So in the spring of 1992, Sharon and her husband, who has also since died of AIDS, engaged in a brief political campaign, which is pretty unknown, but was quite substantial. It had substantial effects, I'll tell you. They engaged in this campaign to increase the awareness of the unavailability of methadone and to demand more methadone. I didn't do much. We let them use our office Xerox machine, bought them a staple gun. The man, Sharon's husband, was quite artistic, and he drew this on a paper which we copied, and it was stapled from one end of Toronto, from the very west end, west of Parkdale, to the east end. We had a deep stethoscope, as I call him, within the Ministry of Health, who gave us Michael Decter's private inside office number at the Ministry of Health. And this was on a cold Saturday morning in February 1992. I'll have to tell you that Mr. Decter's office was flooded and inundated with phone calls from that Saturday afternoon on. In fact, he had to hire a full-time secretary for about the next month and a half just to keep on taking the calls. The 2 patients had instructed the government in the most palpable of fashions about the desperate need for methadone treatment. Michael Decter left an urgent voicemail in my office that Saturday afternoon. It was impossible to get hold of Decter. He was Deputy Minister of Health. Could never get hold of him. He wanted a meeting Monday morning. I was a little bit brash and cocky and said, you know, I'm not prepared to cancel my patients for you, Mr. Decter. You're going to have to wait till Tuesday. And he came in Tuesday, and he came in like this. He sort of sat erect in the chair. He met with myself, with Mary Grondin, and with Sharon, who I mentioned was this type of person that you could not help but adore. And he came in very defensive. He stayed for a full hour. By the end of the hour, he'd slunk back in a chair like this, and he said, I promise you 100 more methadone spots in the city of Toronto. And he kept his word. The Ministry of Health issued a press release about April and May announcing a $450,000 grant to Parkdale Community Health Centre to fund methadone spots at the time. In fact, the number of methadone spots in Ontario has actually increased by 400 times more than the original 100 spots promised by Mr. Decter. So this just goes to show you what 2 quiet, anonymous people who nobody knows about anymore can do to change dramatically addiction treatment policy in Ontario. They did it almost single-handedly. As I mentioned, all we did was give them a staple gun and our Xerox machine for use. Now, after Sharon died, a number of staff organized a memorial for her at the Wellesley Hospital. It was quite an event, quite something. The few of us who planned the memorial service had no idea what would happen or who would even come, if anybody would come. The only plan was for me to give kind of a sermon-like presentation, brief, talking about her. As I mentioned, we didn't know who would show up, but in fact, a lot of people showed up. It was held in the chapel of the Wellesley Hospital, and it was jam-packed, standing room only. There were workers in various social service agencies, health agencies, and there were well-known junkies and pushers. I say junkie not in a pejorative sense. It's how my patients call themselves. I don't mean it in an insulting way, but they were there full-fledged in many numbers from across the city. Had some of the biggest pushers in the city were there. And also was Dr. Jay Brown, who's the former director of the Ontario Government AIDS Bureau, who actually died in January 2013. He attended on behalf of the government without any formal request being made to him or the government to attend. He'd heard about it. He was a towering figure, Jay, in the fight against HIV and AIDS. He was fearless and ferocious in taking on anyone who got in the way of the best interests of people with HIV and AIDS. And he was almost single-handedly responsible for bringing together AIDS activists and the government in the late 1980s. That was no small feat, believe me. But back to Sharon's memorial, I gave the introductory remarks not knowing what would happen, but it didn't take more of a moment of hesitation, really, for a stream of people to get up and talk, including the mother of an addict with AIDS. Her son at that time was incarcerated in the Toronto jail. Also a heroin addict who had left the addictions world for religious fundamentalism. Another heroin addict with HIV who became active in her own Aboriginal community. And several others who were in their own ways dealing with AIDS and addictions. But it was Jay Brown, Dr. Jay Brown, who had the greatest impact at Sharon's memorial. He kind of stood up and he gazed over this crowd of disparate people, varied individuals, professionals and addicts, and he declared in this sort of famous Kentucky accent that we're going to take care of you addicts at the memorial. And a cheer went up, whistling and cheering and clapping, with cries of approval from the group. And this is all in the middle of a moving, allegedly solemn and fairly unusual memorial. And as Jay, I think, gazed at the addicts around the room, he saw more than a room full of hardened criminal junkies. He saw individuals just like Sharon who could not only remedy their own situations, but could remedy the social and health system conditions that were preventing them from getting treatment they needed, impeding their health recovery. And he offered his assistance, and he meant it, in making healthcare services accessible and appropriate for addicts. Now, HIV care has advanced, of course, substantially over the last 30 years, and barriers to patient autonomy have been broken down. Experimental drugs are accessible mostly without impediment, and human rights for persons with HIV have been largely, not completely, but largely secured, especially compared to the early 1980s. Over the past 18 years, patients dying of AIDS have benefited from research sponsored by the pharmaceutical industry, and many patients have experienced, I'm sure you've seen this, spectacular and unimaginable improvements in their health. In the spring of 1986, I had a patient who was acutely ill and was admitted to hospital with a gastrointestinal disorder. It was unknown. He's also fairly wasted and was eventually diagnosed with Kaposi Sarcoma, which he had in his mouth and eventually in his gastrointestinal tract. He was dying, but he survived his hospital admission, and while in hospital, he was started on this new combination antiretroviral therapy. When I saw him about a month later, after starting the drugs, the Kaposi's on his mouth had completely disappeared. He had no evidence of it in his gut. It was the first time I'd ever witnessed the regression, the actual disappearance, gone, of Kaposi sarcoma in all my years of being an AIDS doctor. In fact, it was just unbelievable to me. If you had told me back in those years that Kaposi's would be treated to the point of going away, I would have thought you're a mad person, like out of your mind. It just could never happen. And there it was, like melting away before my very eyes. And the end of June 1986, I had a patient who was dying at home of AIDS, and he had wasting syndrome, completely withered away. He also had quite a severe dementia. I decided to go see him at home to basically say goodbye, because I was on my way to the Vancouver International AIDS Conference. I wanted to, see him to bid a final farewell. But around the same time, just before I left, he began to start taking highly active antiretroviral therapy, HART. And by the time I got back from Vancouver, I took a little holiday and I was there about 3 weeks later. He was no longer bedbound or housebound, and he in fact returned to his life of partying at the bars, going to the bathhouses, and dancing in the streets of Toronto. And he actually remains alive to this day very well, with an immune system that's practically functioning at the same level as someone without HIV. He's funny as ever and enjoys his life immensely, does a bit too much drugs sometimes, but drugs literally saved him. Now, the new HIV drugs, of course, have fundamentally transformed the landscape, the world of AIDS in developed countries. The first-hand experience of AIDS doctors is also reflected in the epidemiological reports issued by the Canadian government. So just for example, just to show you how dramatic the effect was, in 1994, adjusting for reporting delays, there's about 1,850 new cases of AIDS reported to the federal government. In 2001, that number had dropped to 452. In the year 1995, 1,482 Canadians died of AIDS, yet in 2001, that number dropped to 81. I couldn't even find on the internet any more recent reports of numbers of AIDS deaths nationally, to tell you the truth. So the numbers are way out of date, but the drop in death rates was profound, and the drop in new diagnosis of AIDS, dramatic. Now, as you all know, the conditions are not quite as hopeful in AIDS-ravaged sub-Saharan Africa. In August 2004, the Ontario Hospital Association announced it would send a team of healthcare professionals to the Sapong Clinic in the Motabong Hospital in the district of Laribe in Lesotho, a tiny southern African country. As I mentioned before, it's landlocked, but about 1 in 4 adults are HIV infected. The reason the OHA chose Lesotho is because Stephen Lewis had given an address to one of their annual meetings, and he challenged them to do something about AIDS in Africa. They agreed to fund this team, which would twin with the first publicly funded AIDS clinic in Lesotho. Why was Lesotho chosen? As I mentioned, 1 in 4 adults HIV infected, but it was also a very, very poor country, a small country, many deaths of kids, a lot of orphans, incredible poverty, new infections outpacing deaths, daily 50 deaths. Now, the Ontario Hospital Association actually arrived for World AIDS Day, December 1st in 2004, and I was appointed the first team leader of the project. I've returned actually twice since then after my initial stay. The team arrived really just over 3 months after the project was publicly announced. There was a big gala held, it was all reported in the newspapers. But the short planning was considered reckless by many in the NGO international health field. Normally these things can take a year and a half to plan. The mandate of the Ontario Hospital Association project, called OHA Africa, was to assist in the distribution of antiretrovirals, but mainly to pass on expertise, experience, and knowledge to the local Basotho staff who are working in the clinic, and leave the clinic in their hands after a 3-year memorandum of understanding with the Lesotho government expired or ended. This is a project of so-called capacity building. But there was one big problem, of course. There were so few Basotho staff with whom we could actually share our experience. It became evident within hours, literally, of joining this clinic that capacity building, at least during our tenure, would be completely impossible. We were thrown right into care. And capacity building, which is a term I have to tell you, I've really come to detest over the years, is unachievable in countries bereft of healthcare systems and healthcare professionals, many of them themselves, of course, are still dying of AIDS in great numbers. Now, the Laribe district, which is the rural part of Lesotho, and the Sapong Clinic in that district, the Sapong Clinic is responsible for the care of about a catchment area of 150,000 people. So rural area, 150,000 people, 1 AIDS clinic for a population where 1 in 4 are HIV infected. In fact, the rural area around Laribe has about the same population as Sudbury, around 150,000. There's one big difference because about 40 to 50 AIDS corpses per week were delivered to the funeral home for preparation and burial a block or 2 from where our clinic was located. Just picture 200 AIDS corpses a month being delivered to funeral parlors in Sudbury. For how long would that be tolerated? Now, each clinic day began with prayers and religious songs. AIDS clinic waiting room was really a hospital corridor with benches that had no backs on them. We had patients who would sit in these benches and just slip off and die on the floor of the waiting room. Very few facilities, a wheelchair with no back wheels to transport weak and ailing people with AIDS. And sometimes a commode, which is in front of the wheelchair, be used to wheel struggling and sick people to our clinic. Now, I spent over 7 months initially at the Sapong Clinic in Lesotho as the first team leader, as I mentioned. I sat in the board of directors of OHA Africa, which is an independent NGO which administered the project. But the project ended in March 31st, 2010. It began December 2004. It ended when the memorandum of understanding with the Lesotho government expired. It was purposely not renewed by the government. There were tensions. There is a matter of national pride in having white Canadian healthcare professionals, largely white, coming to a black, impoverished country and kind of overtaking their care. It's not an uncommon political reaction, but by the end of, near the end of March 2010, that was the number of patients we had registered, about 10,000 active people in a rural area of 150,000 population, and almost 3,600 people were currently on antiretrovirals. At the time, the government said they were not going to renew the Memorandum of Understanding. And to give you an idea how the staffing worked, you can see on the right, on the left rather, that was the OHA team. The OHA team funded 85% of the staff. The government of Lesotho, the Ministry of Health and Social Welfare, funded very few relatively. And the problem was the government would not commit to us that they would continue to hire the staff that we were paying for. And at the end of the project, in March 31st, 2010, this is going on in January and February 2010, and we knew if they weren't going to hire the staff, the clinic would collapse. You'd have 3,600 people in the ARVs who wouldn't get their ARVs, with all the problems of drug resistance because of drug interruption and of death and the illness that would ensue, of course. So after months of numerous communications with the Lesotho government, from the board of directors of OHA Africa to the Lesotho Minister of Health and to the Prime Minister of Lesotho, without getting any answer, we expressed our serious concerns about the sustainability of the clinic. And in the letter we sent to the Prime Minister, we actually finally decided to release and leak to the Globe and Mail. Jeffrey York, who's still the South African correspondent, front page article on this ended up in the Globe and Mail about the Canadian donors fearing the crisis that would result if the government didn't fund those staff. I can tell you the article caused the Lesotho government tremendous upset and consternation. The High Commissioner in Ottawa sent a letter out to many AIDS organizations in Canada, kind of denouncing and complaining about what we'd done. There's some follow-up articles quite critical of us. But in the end, the staff were maintained and the clinic did not collapse. And my view has been that HIV has never recognized national sovereignty and boundaries of countries, and I didn't think that we should when the lives of people were at risk. In this case, mind you, with foreigners, we the rich Canadians who publicly challenged our partner, the government of an impoverished, suffering African people, perhaps impolite and probably contrary to well-established NGO protocol, but necessary in my view. And so I think the lesson is it's okay to challenge the orthodoxy of global health and in any area when people's lives are at risk, and if being impolite might actually save lives. I'm just going to end with one quick final story. A few years ago, a man in his early 60s came to see me. He was diagnosed with what's called idiopathic thrombocytopenia. For those who are not doctors in the room, it was a condition where the platelet count of cells that let your body clot if you cut yourself is very low. So he had very low platelet count. He was, I thought, married. He had, over the course of our 16-year professional relationship, periodically referred to his wife, Barbara. His low platelet count, in fact, was eventually confirmed as benign. But he asked me why I had never raised the possibility of HIV being the cause of his low platelets. And to tell you the truth, I'd never considered it. And I told him I'd never considered it. I discovered, in fact, that he'd been divorced for over 10 years, but had maintained a very close relationship with his former wife. Further, he had engaged in one risky sexual encounter about 5 years earlier. He kept pressing me. I had a very good, healthy, open relationship with him. He chided me for making presumptions about him, that he was still married and in a monogamous relationship. He pointed out that even if he had been married, why did he not consider an extramarital affair with a woman or a man, and therefore the possibility of HIV? I was completely embarrassed and ashamed. He was absolutely correct because I'd stereotyped him. And I broke my own lesson about never gazing beyond the stereotype in the individual in my office to consider personal or social or sexual circumstances that could give rise to HIV and a low platelet count. As it turned out, luckily, he was HIV negative, but I can tell you, as I mentioned, I was acutely embarrassed, especially after all these years of being in HIV and AIDS medicine and teaching medical students not to stereotype and to ask all these penetrating, private, intimate questions. I don't think I've still broken loose from my own conditioning. my own limited vision of this individual patient. I hadn't gazed beyond the gentleman in my office. So just to conclude, I'd like to say the AIDS epidemic has been really quite a trip and a half, from the shock and horror of the early days to the roller coaster of hope and disappointment in the middle years, and finally to the optimistic realization that lifetime control of HIV is highly possible. Actually, I think it's really the case right now. People newly infected can expect to live a normal lifespan with current and future therapies. In my opinion, leaders of the AIDS movement, many who came from gay liberation, successfully turned many institutions topsy-turvy, as I mentioned, whether it's the healthcare and scientific field, public health system, and in particular, the nature of the doctor-patient relationship. I consider myself, in an odd way, lucky and privileged to have found myself, really quite by accident, on the front line of the AIDS epidemic since it began in Toronto, despite the despair I and others often felt in those first terrible 15 years. The practice of AIDS medicine's at times been frustrating, other times exasperating, but it has provided doctors with intimate glimpses into the lives of patients who not only had to contend and encounter a new and bewildering infection, but had to contend with the initially ungenerous and unkind response of governments and society. So thank you for so patiently listening to me.